and it becomes increasingly important to detect cardiac abnormalities because of the strong association with single gene mutations. Not just trisomy 21 and 18 and 13 and microdeletions, because I'm talking about single gene mutations that can only be identified on wide exome sequencing. We are in a completely new world, a new world of marrying deep genetics with structural malformation. And I want to share with you why it is so important that we make a diagnosis in the first semester. Because for us to understand a genotype, we have to have an accurate phenotype. I've just started. We have to have an accurate phenotype. So it becomes critical in terms of screening and diagnosis. So what we do is we offer cell-free DNA at 10 weeks, and we schedule the anatomy scan at 13 weeks of gestation. And if I ask you a question, if you go to work tomorrow morning and you identify a cardiac abnormality, what are the chances that the baby's going to have an abnormal genetic result on your chromosomal microarray testing? What are the chances? 5, 10, 15, or 30? Anybody? The chances are 30% the baby's going to have an underlying chromosome abnormality to explain it. And if I then ask you the question, if you find something else, like an AVSD, a polydactyly, or a facial cleft, what are the chances the baby's going to have a cardiac abnormality? Is it 10%, 20, 30? It's 50%. Now that's very important information, because when you look at cardiac abnormalities, we spent the last 25 years looking at aneuploidy, represent 50%, and only a 5% yield with microdeletions, of which half of those are 22q deletions. Now look at where we are in 2026. That you have an isolated cardiac abnormality, you will add an additional 10%. And that's where the 30% comes from. And if you find that there's an additional abnormality, the monogenic causes rises to 30%, giving you a 1 in 2 chance that if you identify a cardiac abnormality with something else, that you're going to find a genetic cause. No woman wants to find the result of an exome sequencing at 26 weeks of gestation. Because if you do your screening at 20 weeks of gestation, by the time you run through the cascade of genetic investigations and get your WES result, she's going to be 26 to 27 weeks. That's very, very late in the pregnancy. But if you make the diagnosis in the first semester of pregnancy, you will have the result of the exome sequencing by 17 to 18 weeks of gestation. That is one single slide. That is an extremely important slide if you want to take out your cameras and take a photo. Because in one page, it tells you all the details you need to know about cardiac malformation and the association with genetic abnormalities. It tells you the percentage of cardiac abnormalities from trisomy 21, 13, Turner's, triploidy. It tells you the percentages of microdeletions, half of them are related to 22q, and then it tells you what the monogenic disorders are in that 30%. That single slide is just worth having on your room for the next time you identify a cardiac abnormality. Now, the ISRU guidelines in 2023 came up with a recommendation that we include in the cardiac assessment not 5-section analysis in the first semester, but only the 4-chamber and the 3-vessel tracheal view, including color. This is a game changer. It's going to turn around our detection rate. And if I turn around and say to you, well, Simon, what are the facts and figures about our detection rate? If you go back to over 6 years ago, from Kypros Nicolaides' unit of 93,000 pregnancies screened, about 1 in 400 babies had a cardiac abnormality. And the detection rate then was about half of them were picked in the first semester of pregnancy. We've come along a long way since then. And with Iris Papageorgiou's paper, if you look at it with a dedicated protocol-based approach, with a 4-chamber and 3-vessel tracheal view, that you will identify the majority of major structural maladies. But only if you have a protocol. Only if you have a dedicated 4-chamber, 3-vessel tracheal view on both 2D and color Doppler examination. If you don't have a protocol, your detection rate is 30%. This is across 328,000 pregnancies, this data. It's a huge data set, and I hope it convinces you that that's where we are today, that we can detect the majority of major structural anomalies. And now I'm going to run through those quickly with you, because I think it's important to understand that in detecting cardiac abnormalities that there are three groups. The ones that you will always see, the ones that you will sometimes see, and of course there will be cardiac abnormalities that you will never see. Just like in the second trimester, there are cardiac abnormalities you will never see. I'm going to go through the ones that you expect to see during the first trimester of pregnancy, the always group. I never like saying always, let's say in the majority of cases. In this case, we have a 4-chamber view of heart, and the left cardiac ventricle is not visible at 13 weeks. We sweep to the 3-vessel tracheal view with a dilated pulmonary artery with reversal of flow on the transverse aortic arch. Exactly the same appearances at 20 weeks, but you're making the diagnosis at 13 weeks on a 4-chamber and 3-vessel tracheal view with color and 2D. In this case, is a hypoplastic right heart, so there's no visible right cardiac ventricle. And this is the same patient with a high-frequency probe, moving up to C2 to 9. There's no visible right cardiac ventricle. And then you sweep up to a 15 megahertz. It looks like 20 weeks, but it's actually a 13-week pregnancy. That's the power of revolution in the first trimester with high-frequency probes. In this case, when you look, there's no visible left cardiac ventricle, or it is smaller when compared to the left. Right is smaller, and then you see a VSD with minimal flow across the right AV valve in a fetus, tricuspid stenosis, and a ventricular septal defect. This is a fetus at 13 weeks and 1 day of gestation. In this case, a common arterial trunk at 13 weeks of gestation, with the common arterial trunk arising from the right cardiac ventricle. Common arterial trunk type 1. Where you can see the pulmonary artery coming off the common arterial trunk. 40% of common arterial trunks come out of the right ventricle. The other 60% sit astride both ventricles. Common arterial trunk, type 1, giving off the branch, main pulmonary artery, and with the aorta coming sweeping around with the question mark sign. Again, most of these common arterial trunks are picked up in the first trimester. 4-chamber view of heart. When you sweep up to the 3-vessel tracheal view, you see red, blue, red, blue, red, blue. No arterial duct. Findings typical of absent pulmonary valve syndrome. Not a diagnosis that you are making at the mid-trimester, a diagnosis that you are making in the first trimester of pregnancy. We don't wait anymore to making this diagnosis at 20 weeks. We make it at 13 weeks by using color Doppler and seeing bidirectional flow. When we look at the 4-chamber view of heart, in this case, we see a atrioventricular septal defect. Again, for most of these in this series, 72% and 90% were identified in the first trimester. And when you see an AVSD, you split your image to ascertain the position of the stomach in relation to an AVSD. And in reference to this, the strong association of this with the isomerisms. But you're not making the diagnosis at the mid-trimester, you're making the call in the first trimester. And in fact, if you look at the heterotaxis, these have the highest yield of single gene disorders. It's imperative for that patient at 13 weeks of gestation that you don't go straight to a microarray, you go straight to an exome sequencing, or you run them in parallel, because you have a greater than 50% chance that you're going to get a result on exome sequencing just on the cardiac anomaly alone. And when you see with the AVSDs, your next step is to look at stick volume analysis, and you can see the common AV valve. You can actually see the regurgitant jet using with stick 2D in a heart for 12 weeks and 6 days of gestation. You go to the 3-vessel tracheal view, which shows a normal pulmonary artery and aorta, just to confirm that it's an isolated common AV valve defect. Then you're left with the complex anomalies. These are anomalies that are in the always group. We get normal fill of the left ventricle, but no flow across the right AV valve. When you go to endovaginal assessment, you see that there's a ventricular septal defect. You then next move to putting on color Doppler according to the UCO guidelines, and you see as you look on color Doppler examination that both vessels are rising out of the heart in parallel. You now have got no flow across the right AV valve, a ventricular septal defect, and both arteries coming out in parallel. You then go to a stick volume analysis, and you see all the features on a stick volume analysis. In a fetus with tricuspid atresia, ventricular septal defect, transposed great arteries, and the pulmonary arteries smaller, pulmonary stenosis, and also had a dilated coronary sinus. But you're not making the diagnosis at 20 weeks, you're making the diagnosis at 13 weeks of gestation. An extremely complex abnormality, but the point I make is that you can work these out because you have the benefit of a high resolution ultrasound probe. This condition, I would say, is 100% detection rate. They typically have an enlarged heart. They typically present with mitral and tricuspid valve regurgitation. And as you go to look at the three-vessel tracheal view, you not only see bidirectional red, blue flow of the pulmonary artery, you also see the transverse aortic arch. Every single valve in this baby's heart is leaking, is abnormal. This is polyvalvular dysplasia, and in the series reported, all of these are detected prenatally in the first trimester of pregnancy. It is so detectable by simply using color Doppler. And the next thing I'll tell you is they are almost all are going to be aneuploid. In fact, you can pick it up even earlier. This is a 10-week pre-NIPT scan, and when you look with color Doppler, you see bidirectional flow across the great arteries in a heart that measures 4 millimeters from apex to base and 3 millimeters across to side. We are picking these up earlier in the first trimester of pregnancy. And then there are rare cardiac abnormalities. In a patient who I scanned in Vietnam back in 2024, I think it is, and you say, this baby's got bilateral pleural effusions. I say, no, it doesn't. The lungs are pushed posteriorly. This is a baby with a large pericardial effusion. But stick volume analysis tells me there's something strange going on at the apex of the heart. In fact, look at the left ventricle. It's smaller when compared to the right ventricle. I then look at the cardiac inflow into the left ventricle, and I see the cardiac inflow of the left ventricle is significantly smaller when compared to the flow into the right ventricle. And when I go then to looking with the rendered image of it, I can see the atria of both sides, which in this case, staging gestation the first trimester, are much larger in reference to the size of the heart in the second trimester of pregnancy. And then using stick render silhouette and changing the light source behind the baby's heart, I can watch without color, and I can see the direction of flow of blood entering in from the left ventricle into the cardiac diverticulum. A diagnosis made not at 20 weeks of gestation, a diagnosis made in the first trimester. The other abnormalities that we pick up, almost all of these in the first trimester, is the cardiac extrapies. The heart is sitting outside the thorax. There's a single ventricular chamber, and most cardiac extrapies have a coexistent abnormality. But using stick volume analysis, you can see a single ventricle with 2 atria, and quite typically bilateral hydrothoraces. Again, for these, we pick them up very early in pregnancy at 8 weeks and at 10 weeks of gestation as a very early first semester diagnosis. We move to the next group, which are the groups that are detected sometimes in pregnancy. And when you look at this case, you sweep from a 4-chamber up to a 3-vessel tracheal view, and as you do so, you only see 2 vessels, not 3 vessels. And the curvature coming out of the right ventricle is reversed. It should be like this, but the curvature coming out of the right ventricle is reversed. And then you move on to the LVOT view, and you see both great arteries coming out in parallel. This is referred to as the boomerang sound. And we reported this in the first trimester of pregnancy, and also reported the same finding as a sonographic marker in the second pregnancy. It's a very powerful marker of TGA. All of these babies have transposition of the great arteries. All of these babies were picked up by my sonographers in the first trimester of pregnancy, simply by applying a rule of taking a 4-chamber and 3-vessel tracheal view with color Doppler and recognizing two things. There were only 2 vessels on the 3-vessel tracheal view, and there was a reverse curvature of the vessel coming out of the right ventricle. And here's another 3 cases on top, which is transposition of the great arteries, and then 3 more cases on the bottom, which are transposed great arteries, but in the setting of a more complex coexistent abnormality, typically double inlet left ventricle, which you may get transposed great arteries. So applying the simple rule of splitting in an image and showing a 4-chamber and 3-vessel tracheal view, you can identify these. Coarctation is a very challenging diagnosis. Not all of these are picked in the first semester, but again, the same principles. The left cardiac ventricle is smaller when compared to the right, and the transverse aortic arch is significantly narrowed when compared to the dilated main pulmonary artery. The same features that you see in the mid-trimester, you are seeing in the first trimester of pregnancy. Tetralogy of Fallot, when you've got a 4-chamber view of heart, you see a ventricular septal defect, the first thing that strikes you, and then using the new graphic flow, you see the dilated branch, the dilated main aorta coming out and being fed by both the left and right ventricle, feeding into the dilated aorta. And in fact, the dilated aorta with the turbulent flow can be identified in transvaginal examination with color Doppler or indeed stick 2D evaluation. When you look at tetralogy of Fallot, you say, Simon, how do you pick these in the first trimester? I will say to you the most useful markers is on the 3-vessel tracheal view, you have a Y configuration because you have here the main pulmonary artery, the duct, inserts more proximately when compared to the aorta, whereas the normal 3-vessel tracheal view should be like so. In this case, you're getting a letter Y configuration. And the second powerful marker is that the heart axis is rotated to the left. And this is how the sonographers pick it up, by seeing left cardiac axis deviation and the Y sign. Here are 6 cases of tetralogy of Fallot, all demonstrating that Y configuration of that shortening of the arm of the arterial duct against the lengthening of the arm against the aortic arch. And then there's double outlet right ventricle, very straightforward. You sweep from a 4-chamber to a 3-vessel, and you see the vessels do not cross. Everybody in this room knows that when you sweep from a 4-chamber to a 3-vessel tracheal view, that the great artery should cross. But in this baby, they don't. They come out in parallel, and this is a double outlet right ventricle. I think everybody in the room will recognize when you look at this 4-chamber view of heart that the right atrium is enlarged. And the right atrium can be enlarged because of an aneurysm, but more commonly in the first semester it will be enlarged because you have Epstein's anomaly. But you have to decide, is it Epstein's anomaly arising deep inside the right ventricle, or is it tricuspid valve dysplasia arising at the level of the right AV valve? Only by looking with color Doppler and with the help of stick, you determine that this is deep inside the right ventricle and therefore Epstein's anomaly. Another case of Epstein's anomaly at 13 weeks of gestation, with dilatation of the right atrium, regurgent jet arising deep from inside the right ventricle in a heart that measures 9 millimeters by 7 millimeters. I can tell you that's 13 weeks. In contrast, when you look at this heart, which has got severe tricuspid valve regurgitation, the position of the septal leaflet of the tricuspid valve is normal. It is not Epstein's. And the regurgitant jet is arising from the level of the AV valve, not deep inside the right ventricle. This is a fetus with tricuspid valve dysplasia. This is the fetus with Epstein's anomaly. With regard to Epstein's anomaly, you will see far more cases of Epstein's anomaly in the first trimester when compared to the second. Why? Because in the first trimester of pregnancy, many Epstein's are associated with aneuploidy, in particular trisomy 21. This baby with trisomy 21. When you look at the stick evaluation, you can see that regurgent jet. I'll make that point again and again. Just like in tetralogy of Fallot on 2D, you see that turbulent flow without even using color Doppler. Why? Because you're using a high frequency endovaginal probe, and that gives you the detail you want. With routine use of color Doppler, we are increasingly going to pick up right aortic arch. And as you appreciate, you do not have a V configuration in this fetus. In this case also, when you look here with the newer technologies of graphics flow, in in this case at 13 weeks of gestation, you see that typical U configuration, not a V configuration. And why is it important to pick that up at 13 weeks? Because we know the association of this with 22q deletion. Remember, of the 5% of cardiac malformation that are related to microdeletions, half of them would be 22q. And that's a very identifiable abnormality in the first trimester of pregnancy. You can also pick up double aortic arches. This is the fetus at 13 weeks